I have to thank Dr. Grant for the invitation to be here, and ASAP. I've been associated with ASAP for quite some time, and it's difficult to follow. You know, they call it wind out of my sails if you're a sailor, with all the people who talked before me. Great talks, very instructive. I don't know how much of it went over my head. So let's... You know, we are referring this as the Hindbrain Herniation syndrome. I don't know what I tipped off or something. So we call it the Chiari 1 abnormality. It's traditionally been defined as a downward herniation of the cerebellar tonsils through the foramen magnum of more than 4 to 5 millimeters in the mid-sagittal plane. This is associated, believe it or not, in syringomyelia, and looking at all the literature from way back, in about 45 to 60% of patients. It can occur in conjunction with bony abnormalities of the region. So what we have is changes in the dynamics of the cerebrospinal fluid, which contribute to the symptoms and signs that you all know about. We've talked about Valsalva headaches, lower cranial nerve abnormalities, and spinal cord changes that overshadow the syrinx. So what are we seeing here? We've got an MRI with the Chiari 1 abnormality, but there's no bony distortion, except in terms of the volume of the posterior fossa. Here we have a 3D image which shows the bony abnormalities in this child. What are we seeing? We are seeing a segmentation failure. When in doubt, use your own. So we've got a segmentation failure here. This is C1. Part of it is still incorporated. It's not separated from the skull. Part of it is separate from the other. If we look at a 2D, what we're seeing here is there's segmentation failure of the first bone from the skull. This angle is wrong. That angle should be 125 to 135 degrees. It's getting close towards being acute. Let's look at it on MRI. You can see that the front abnormality now is digging directly into the medulla. That's where you live. There is a Chiari abnormality associated with it. I'd like to use the term instead, the hindbrain herniation that's coming down. Now we've got a syrinx present here. That's a patient post-op, same patient. The syrinx is gone. What have we done? We've taken away the front compression, taken away the compression from the brainstem. The syrinx has gotten much better. And what did we do? We've given more volume by taking away the pressure from in front. This is pretty critical. Keep in mind, we don't have an animal model for Chiari abnormality. St. Charles Spaniels, they all have Chiari abnormalities in syrinx. But you can't extrapolate from the animal to us. So that's essentially what we did. This is a composite of pre-op and post-operative with an artist's view. The slide to the left shows you the ventral compression, shows the syrinx, the hindbrain herniation. We've taken away the ventral compression. Brainstem has been relieved. Tonsils go up on their own. In a recent comprehensive review by Tom Millerot, who was one of the giants who was in this organization, he found a syrinx in 65% of patients. Scoliosis was in 42%. An abnormal odontoid process which pushed backwards was in 26%. Basilar invagination. What's basilar invagination? Just think of a pumpkin and a spike. Does the pumpkin come down? Does the spike go up? That's basilar invagination. Occurred in 12% of patients. Now, mine is a skewed population because I see patients with a lot of bony abnormalities plus the other problems. Tom saw basically this huge cohort of more than 375 patients that they originally published. Roger Kula was part of that in late 1990s, probably 1996 or 1999. And it's held true. So we've got to be very careful that there are bony abnormalities. You can see here it's probably a third of patients. The posterior fossa decompression as a treatment for Chiari 1 abnormality with syrinx has shown satisfactory results, except in the presence of a ventral bony abnormality. In the latter circumstance, you'll get adverse outcomes, which can be seen within a few weeks to a few months, maybe a few years. There's a large volume of literature that started out when I was a resident that was very frightening. These were people who had guts to go ahead and say, these are the complications that can occur if there's a problem from in front. And 1/3 of the patients died within the first 3 days. There's been a large volume of literature. Finois was mainly a review of our series. Nate Selden talked about the Portland series. Tom Millerot and Muweni has talked about the San Francisco series. This is a database analysis of patients with irreducible or immobile ventral compression. Ventral means from the front of the craniovertebral junction that's between skull and spine. When we use the word craniovertebral junction, we're talking of a bone. When we talk of cervicomedullary junction, that's the neural structures. An irreducible abnormality is one which does not change with motion or traction. We usually stop our reviews at least giving 4 years before publication. Why? Because recurrence and problems occur usually within the first 22 to 28 months. That's literature. So you skip and you go back. You say, we'll expand our search and our review to at least 4 years. In this database, now these are not just Chiari abnormalities. These are patients who've got craniovertebral junction abnormalities. In this database, we had over 6,000 patients. It's huge. 762 underwent a ventral decompression of the cervicomedullary junction. 315 had irreducible abnormalities at the craniovertebral region, and these were patients who had this group who had Chiari abnormalities. The studies, you've seen all the studies, that I won't belabor you with that. "90 patients had a syrinx. Of these 90, those are the patients who had Chiari, syrinx, and bony abnormalities. 74 had a primary bony basilar invagination. Again, think about it, pumpkin on a spike. In 16, the invagination was secondary, and that occurs in patients who've got problems such as osteogenesis imperfecta and the bone softening states. Paget's disease. A third of the patients had previous posterior fossa Chiari decompression procedures, including fusion. All these patients had brainstem myelopathy, spinal cord symptoms, lower cranial nerve palsies. This is a representative case of a ventral bony abnormality. showing compression of the medulla. What's medulla? That's right here. And then you see the tonsil ectopia coming down. Here's another case, similar situation, basilar invagination, syringomyelia, and these are slides. If they look like they are old, they are old. We have a database. This database goes back to 1977. So we are able to pull out before MRI, before myelograms. Now we are able to say, what did we miss before? And what are things that we should be looking for? So this is really what you can do in an academic center. This is a patient who had a secondary form of basilar invagination. The slide to the left shows the compression from in front and the hindbrain herniation with the syrinx cavity going all the way up. The slide to the right is after the vent front decompression. The syrinx has now nearly disappeared. All patients underwent crown halo traction. That means we're trying to see if we can disengage the pumpkin from the spike. Mind you, these are the patients who had the front abnormality, not the back problem alone. And then they underwent a decompression. How do you do it? Go through the mouth. It's been usually done with an open procedure. Everything is with a microscope. And you decompress the front of the brainstem. Those patients also require a posterior procedure. And if they've got abnormality such that you say a big syrinx and you're saying, well, the syrinx hasn't gone down, they need an intradural procedure, and all of them require a fusion. Before 1992, these were two separate procedures. We didn't have enough of experience. We were not speedy enough. The front operation takes, with all the mechanics that go on with anesthesia and traction and your studies, the front procedure, we have to give at least 6 to 8 hours. Then you add another 6 hours to it. We're pretty tired. And then I decided, hey, that's it, it's worth it. Try to get it all done together. But before 1992, this is the catch. Before 1992, these were two separate procedures. We did first the front, then an MRI, and then after you knew that everything was well, a week later, you did the back procedures. Now, as I said, they're all done in one. Except in the last 5 years, because we are seeing more and more complex stuff, we've gone back to doing front first and then wait. So what are we seeing here? This is a patient who came to us in 1990. The slide from in front, from the left, shows the pressure from in front. And, you know, MRI has changed and improved so significantly. So we took care of the problem from in front. You can see that the syrinx has gone away. So, therefore, it means that a front operation alone can take care of the syrinx. So, if anybody challenges it and says, well, you did a back operation too. No, we had waited. So the post-op MRIs are done in the first week, otherwise 6 weeks and then 3 months. Here's a tough case. This patient had a syrinx. The skull base is all the way up. The size of the posterior fossa, you can see the back of the skull, instead of coming nicely rounded, is going upwards. I think there's too much of light, but you can see a lot of pressure up there. And the syrinx. It's gone. The syrinx is gone. Front pressure is gone. And subsequently, we do the back procedure. Prior to 1992, we had resolution of the syrinx in 9 out of 16 patients. Since 1992, there was resolution in 59 out of 72. In 22 patients, the syrinx did not change and were re-explored. We found scarring from previous procedure, occlusion of the fourth ventricle, you've heard all of this today, by the tonsils that were matted down together, or new bone formation over the previous posterior fossa decompression, or the veil that may be present at the outlet of the fourth ventricle. In most patients, their symptoms resolved after this operation. This is an individual who had the whole constellation of symptoms and signs of compression of the brainstem. Sleep apnea, difficulty breathing, had to be fed by an NG tube. What you have to see is that the syrinx which is present, the 2D on the right side, shows the bony abnormality. The angle between the clivus, that's nearly 90 degrees. I told you it should be 125 to 137. That's denting directly into the brainstem. This is a long reach, no matter what, whether we use an endoscope or not. To get from here to there is a long reach, either from here or here. In this case, this portion of the skull is so short, you can't get in with an endoscope through the nose. That's a post-op scan. Syrinx is resolved. The syrinx and the entire spine has gone away. Again, we're saying long-term. This is a long-term follow-up. This is 10 years out. This is a tough case. This represents a 3-year-old who presented with brainstem signs. He underwent a posterior fossa decompression with a fusion at a very major neurosurgical center. Just keep that picture in mind. He presents at 9 years of age, 6 years later, and look and see what happened to that bone, the odontide process. It's gone straight up into his brainstem. So that's the slide to the left is a side view. The slide to the right is a view, a cross-cut, and the odontide process now has gone and shifted both the vertebral as well as the basilar arteries. The flow voids that you see here, the strings on either side, those are the blood vessels to the center part of your brain. Question came up, can you take down this fusion? Well, was the fusion solid or not? That fusion was solid. This is a composite of the CT, which shows the fusion from behind is very solid, and from the sides. Can you take it down? No, you can't take it down because this is bone that was just put in and has fused to the skull. So we've got to go in and take out the front problem. Well, it's easier said than done, but it was done. So this is immediate post-op. It doesn't look like we've done much, but we've taken out that peg, digging into it. An immediate scan done within 24 hours shows the syrinx is nearly gone. Patient was extubated, did very well. We didn't have to redo the back part because it had already been taken care of. And when we looked for the axial views, now those blood vessels are all free. You know, being an academician, we always throw questions to ourselves. We want to try to get answers. The first question that we have is, why does a syrinx form in the first place? We think the answer is because reduction in the posterior fossa volume, and that the tonsils get impacted. Nothing new, everybody's accepted this. There's blockage of CSF flow, the dynamics change. The second question that we ask ourselves is, Why do patients get worse if they had basilar invagination, especially if they've had a good satisfactory posterior procedure? This is because they get increased angulation. So you've got a peg going in, the head is tipping over forward, that's shoving up further, goes into the brainstem. That's your breathing at your cardiac centers. So there's increased angulation, there's progressive upward invagination, there's settling, that means the head tends to slip forward. That's called a cantilever effect. There's instability, because this wouldn't happen unless if everything was rigid at the back there. And with that, everything gets re-impacted. The growth of the skull takes place up until 16 to 17 years of age. So, if I did a fusion on a child at the age of 3 or 4, or let's say before the age of 10, it is imperative that I follow that patient till they've gone past 20. Because we've got to make sure that this has not happened again. There's examples in front of you. I don't know, somehow I've seemed to have frozen. I'm not moving forward. Okay. So the third question is, why does the syrinx disappear after we've taken out the pressure from in front? Is it because we also have a posterior decompression? That doesn't jive, because before 1992, we showed that if you just did the front, the syrinx went away. So what we think is that there is because you've removed the block, the space in the back of the head now is increased and you're reversing the blockage. You have all heard one of our former colleagues who since passed away. His name was Bernard Williams. He's the one who showed that there is a change that takes place with CSF flow between the skull and the spine when you cough. So when I normally cough, my veins around my spine squeeze, I shove up the CSF into my head. If everything is open up here, it's going to immediately, microseconds, it's going to equalize. But if I've got a tonsil which is pushing down and I push the fluid up, that's when the intense Valsalva headaches occur. Then those tonsils that are pushing down jam down further. It's like a cork in a bottle. You're shoving it down. That's the intense headache, and most patients say, this is the bad, worst headache that I have. Some people actually drop. And then it's a slow burn, the headache goes away. Why? Because the cork is now opened up, or CSF is flowing on the sides. This is just to show you why things change. It's an artist's view. You saw it similarly with the color photographs. One thing to keep in mind, all patients who have a front operation has to have a posterior fixation. So this is a child who came to us at the age of 8. She had cranial nerve abnormalities. I remember very, very well that she had trouble swallowing. She couldn't move her tongue properly. And she had a list of 17 questions. 17 questions, and I had to answer them before I could proceed any further. But she did tell me that one of the problems that she knew that why she needed something done was because when she went to make her first communion, she couldn't stick her tongue out for the host. These are slides from that time. This is 18 years ago. This is T1 and T2 images. The post-op images show resolution of the syrinx and that her symptoms went away. She's now gotten married, she's moved back to Iowa City, and she works in our facility. So in the discussion, the next question that we have to bring up is, why don't all patients have resolution of their syrinx when you do a ventral compression? In other words, there were only nearly 1/4 who needed a second procedure from behind. Well, what we found was that we had missed a whale. The tonsils occupied the floor of the fourth ventricle. There was severe scarring from previous operative procedure and new bone formation. So what are our objectives? As a teacher, we have to ask ourselves questions, and we've got to throw things back into the field to say, we want to wait till somebody comes up with some answers, same as what we are doing. We need an understanding for defining the pathology that's associated with craniovertebral abnormalities, and what we call as the Chiari 1 abnormality. Second, who are the patients who require more than a posterior fossa procedure alone, and why? I think we've answered some of them. It's a long story. What's the pathophysiology of the syrinx going away after the ventral decompression at the craniovertebral junction? Those are questions we ask ourselves, and I don't want to stop here. This is all published. This is in the peer-reviewed journals and textbooks, and I'm going to switch gears, and I want to show, I can put this up for Bob Keating. Bob, this is a 14-year-old girl who first presented at age 11. She had scoliosis, severe neck pain, headaches, and a gait disturbance. She underwent 3 posterior fossa procedures, including intradural surgery, with a syrinx to subarachnoid shunt in the 4th procedure. Her scoliosis progressed, and so did the syrinx. So we get our chance to stab at the cake. And the first thing we do is we want to make sure that there's no bony abnormalities. What you're looking at is a 3D CT of the skull base, and the whole neck. And to me, it didn't look bad at all.